Okay, good evening everyone and welcome to our behind the scenes lecture. My name is Lisa Jerome and I'm the Associate Vice President of Community and Estate Giving at the Toronto General and Western Hospital Foundation. I wanted to welcome you all here and thank you for coming. This is an event that we find is very important for our donors that we put on every spring and fall. And it's important for you to have the opportunity to hear from our experts that we have in all of the areas. And we feature various topics, from topics today in cardiac care, for instance, to dementia, to arthritis and Alzheimer's, etc. So this is an opportunity where we want you to hear from the best and the brightest that we have here, and then ask questions, and we will have some time afterwards where you can ask questions. So as you're going through this and listening, please think about what questions that you might want to ask after our presentation. So we have been doing this behind the scenes lecture for 10 years now, and we are just thrilled to be able to provide this opportunity to you. And I don't know, for anyone who has read our latest newsletter, our report on your support, Dr. Domanski was featured in it. And that's who you will be hearing from today, along with his colleague, Dr. Horlick. So we do have copies outside if you would like to pick that up on your way out. I'm going to introduce Dr. Domanski and Dr. Horlick, and then we will hear from them shortly. Dr. Domanski joined UHN and Toronto General here in September of 2015, so just very recently that he has joined us. He is our new head of cardiology at the Peter Munk Cardiac Centre at Toronto General, and he comes to us most recently from the Mount Sinai Hospital in New York City, where he was a professor of medicine, health science and policy at the Icahn School of Medicine. There he directed fellowships in advanced heart failure and transplant cardiology and chaired the Cardiovascular Institute of Compliance Committee. He started his career in a very different realm, engineering, but it is related, as we heard later today, as he did a Bachelor of Aerospace Engineering, and he got highest honors in that when he started. He did that at Georgia Tech, but then he went on to medical school, and he did that at the University of Maryland, and specialized in internal medicine from Pennsylvania State, and then moved on to do his cardiology fellowship at Vanderbilt University Hospital. In 1987, he joined the National Institutes of Health in Bethesda, Maryland, and there he had a specific research focus where he was developing and executing large clinical trials. Since then, he's received many awards and accolades. In 2006, namely the NIH, the National Institutes of Health Awards, where he was awarded for his leadership in clinical trials and fellowships. He is board certified internal medicine, cardiovascular diseases, interventional cardiology, advanced heart failure, and transplant cardiology. He has authored and co-authored over 200 publications and textbooks, so very extensive background. We're thrilled to have you here at UHN with us. And Dr. Horlick, Dr. Eric Horlick, is an interventional cardiologist at the Peter Munk Cardiac Centre. In 1996, he obtained his medical degree from McGill University and has been the recipient of the Sanofi Cardiovascular Research Fellowship. And the Julio Chavez Young Investigator Award, I'm not sure I've said that correctly, from the International Congress of Cardiology, amongst many other honors that he has received. As with he's received or done many co-authors of various studies as well, and his focus is in the expertise and area of surgical or minimally invasive procedures, which you will hear about later today. And he is involved in training many of the physicians here and fellows, and also in training around the world in this very specialized area. And I do have to say and make a comment that earlier today, they both made this presentation to another group of our donors, and you will be wowed and amazed at what you will learn and the fantastic work that is going on here. So without further ado, I'm going to introduce here Dr. Domanski to come up and share his knowledge with you.
Well, thanks very much. It's a pleasure to be here, and I do thank you all for coming as well. Things have changed very much in the research world. There was a time when there was a lot of government support for research, and increasingly in the United States, Canada, and really also in Western Europe, there really is an increasing dependence and a recognition of that dependence on philanthropy. So it's become a very important source of research support, particularly as government funding has decreased. We do appreciate your support and your being here and chatting with us tonight. So what I would like to do is go through a little bit of what we're thinking about. Not in some encyclopedic way of going over all our projects, but I want to share with you some of the things that we're thinking about, some initiatives that we were either starting or plan to start shortly, and just think about it with you and have some fun looking at them. So one of the first things that we've done since I arrived is we put together a strategic plan. There's I think it was Henry Kissinger talking about Lyndon Johnson's foreign policy, but he was quoting I think he was actually quoting Winston Churchill, but he said, when you don't know where you're going, any road takes you there. And I think that's true. We developed a strategic plan, and a lot of times strategic plans kind of go on a shelf and sort of sit there. This one is much more a living document. What we began with was trying to say, what are our aspirations? What is it that we're trying to be? And there are really three pillars to that. The first one is clinical, and our goal there is to provide a quality of care across our mission spectrum that is the best that's available anywhere. We would like to be able to say that patients who come to us with a particular problem can't buy a ticket, get on an airplane, and go somewhere and get better medical care than they can here. So that's our goal. That's that's what we aspire to clinically. In terms of research, we really want to advance our field. We want to create new knowledge and make a contribution to it. I think also organizations that do research tend to do other things better, like clinical care, because they're really thinking about the frontier and making attempts to advance it. And sometimes you understand a subject much better when you're trying to take the next step. So we think that research is an important component of our academic and our clinical mission. Education as well, and we are educating young physicians and not so young physicians to do things that, in the case of the clinicians, are advanced techniques and learning about the subject, and also learning to do research, which will carry things forward. Education, from my point, is an extraordinarily important job, and it's a responsibility that's considerable. The fact is that when we educate young physicians, we touch the lives of patients we never see, but in large numbers. I mean, as we train groups of physicians, they go out over a whole career and take that training with them. So that's really an important pillar to us. It's not a sidelight. It's really a central issue for us. So that's, those are aspirational goals, and that's our strategic plan. And the question is, how can we implement that? And what I want to do, again, is not to be encyclopedic, but to share a few of the things that we're interested in doing in terms of implementing elements of that strategic plan. So I'm going to talk to you about three initiatives of ours today. The center, and we're calling these centers, a Center for the Prevention of Cardiovascular Aging, a center that involves simulation training. As with aircraft, simulators have become very sophisticated in the medical world too, simulating procedures, and so not requiring one to do one's first try at a procedure on a patient. So we can train people before they ever get into the operating room or into the catheterization laboratory, up to a point. But it's becoming increasingly sophisticated, and we think that should be a central focus of advancing our training mission. And finally, valvular heart disease, certainly one of the important areas of cardiovascular medicine, and one that's advancing very rapidly as catheter-based techniques are starting to replace some of the surgical approaches. So let me walk through just a little bit of the thinking about that, just to share it with you. So let's talk about preventing cardiovascular aging. I think that it's important to define aging and age in a particular way. If we define it as not the passage of time, but rather as the total risk of death or disability, then the perspective changes. After all, there are people in their 40s who have end-stage heart disease, and there are people in their 90s who've never had a problem with their heart. People are different ages at different ages. And I think that that's a concept that, that's important. Now, there are risk factors for it, and certainly the passage of time is a risk factor for the aging in the way that I've described it. But there are other risk factors too, and they're the risk factors for heart disease and stroke, hypertension, elevated cholesterol, family history, smoking, and chronological age, of course, being only a risk factor with this construct. Now, if one carries this to its logical conclusion, then one would say, well, fine, what's the fountain of youth? Can we in fact separate aging from the passage of time? Okay? That, of course, would be the ultimate. We just go on and on and on. And that'd be great. But it's really not feasible at the current state of medical knowledge, and it's a distant construct. My background, of course, was aerospace engineering, but I started medicine interested in this topic and came to the conclusion fairly early in the day that it was a far off construct, and I'm not so sure that we're all that much closer to doing anything with that process today than we were then. But because of that infeasibility, of taking that kind of step, much of current prevention research focuses on reducing risk factors for heart disease and other diseases as well, cancer, stroke, etc. In effect, we'd like to be able to, if we can't stop it, we'd like to at least slow the aging process, as I've defined it. So, in this center that we're putting together, there are several components. One of them is a research component, and that has a couple of facets. The first one is clinical trials, and an example of clinical trial. I want to give you one example of clinical trial, and then an example of a development of a risk factor. Coronary heart disease refers to the clinical manifestations of blockages in blood vessels that give blood to the heart. Okay, so blockage, heart attacks. If we're talking about the brain, we'd say strokes. Indeed, over time, blockages develop in arteries supplying the heart and the brain, and these blockages and clots that form on them then cause heart attacks and strokes. Indeed, heart attack and stroke is the leading cause of death in the world, the developed world and the developing world. And a statistic that I put together is that in the lifetime of a child alive today, heart attacks and strokes will kill more people than all the wars of history. I tried to make it 10 times, and it's not 10 times, but it's not far off that. It's really a remarkable epidemic that we're seeing and suffering through. We have made huge progress in terms of treating heart disease and extending people's lives, but the fact is that statement one is never going to be changed by simply treating established disease. So the prevention is a key step in making the change from an epidemic to not an epidemic. Now, atherosclerosis is an interesting thing. The blockages that form are based on, I'm going to try to, I shouldn't do that the first time, but mistake. Okay, let me try this pointer. This is intended to be the lumen of a blood vessel and then the wall of the vessel. In fact, what happens in atherosclerosis is that the wall of the vessel imbibes low-density lipoprotein cholesterol, bad cholesterol. People use the term bad cholesterol. Never liked it, but it's descriptive. And there are chemical changes that occur in the wall of the artery that ultimately result in the very complex blockages that you see that cause heart attacks. And in point of fact, one would expect that if you deprived this nano machine of its fuel, you might have some success in trying to prevent the progression of atherosclerosis and therefore heart attacks and also strokes. This graphic is a plot of some of the major clinical trials in primary prevention. And you're welcome to look at the graph itself, but what it shows is that the lower the cholesterol, the lower the rate of events, of heart attacks. And the earlier, this is interesting too, the earlier that the lowering is instituted, the lower the event rate. So lower is better and earlier is better. Okay? Important points from the past. Now, this slide is, and what's highlighted in yellow, this is a series of studies, but what's highlighted in yellow is an autopsy series of a group of hunter-gatherers from the 1930s. It's published in 1937 in the East African Journal of Medicine. Say, wow, pretty obscure journal. It is an obscure journal, but it's a very interesting study because what it showed is that our hunter-gatherer forebears who lived a very different lifestyle than the modern, than our modern civilization, or modern society, simply didn't get the disease. The reason that's particularly interesting is that children come into the world with a particular cholesterol level. The hunter-gatherers came into the world the same way. The difference is that they maintained that same low level of cholesterol through their lives, and we don't. There's a gradual increase in cholesterol. So one might imagine, now we're talking about clinical trials we're interested in, one might imagine that if we could maintain in our population the same low level of cholesterol that the hunter-gatherers enjoyed through their lives, we might recapitulate their experience of no coronary heart disease. Now, to do that, we're not going to assume, and this population is not going to assume a hunter-gatherer lifestyle. Fact. But we could actually keep the cholesterol low with medication. Okay? You could start children on statins, on drugs that lower cholesterol. It's unattractive, though, for a variety of reasons. One is their side effects, and you're starting people who have essentially no risk over the next 25 years on a medication that has the potential to have significant side effects, and maybe even side effects we don't know about if you do it for a lifetime. So it's unattractive. But one might ask, in looking at this machine and depriving it of its engine, whether if you lowered the cholesterol, not in childhood, but in the middle years, before complex blockages are present in the population, could you get most of the bang for the buck? Could you get most of the effect that you'd be looking for doing it a lifetime, starting it a bit later? And this is a population-based vaccine-like or probably vitamin-like approach to trying to prevent coronary heart disease. Nobody knows the answer to that question. I think it's true, but I don't know. And a trial, for instance, that we're doing and in the early stages of is a trial that we call the Elimination of Coronary Artery Disease Trial, or ECAD, in which we're taking healthy middle-aged adults and randomly assigning to what is now standard care, or to standard care with the addition of 20 milligrams of Lipitor, a commonly used drug with a very favorable side effect profile that lowers your cholesterol in this setting about 40%. That's a big drop. And we think that what we're going to show is that you can take this population, lower its cholesterol, and make a huge dent in this epidemic. Of course, we may be wrong, and that's why you do clinical trials. That's why you randomly assign people to treatment or to standard treatment versus the treatment we're talking about. We think this is really an important study that could make a difference, and it's one of the things that we're interested in wrapping into this, the research part of our Center for the Prevention of Cardiovascular Aging. Let's sort of change horses now. Now we're going to talk about what we think is a novel risk factor for Alzheimer's disease. Alzheimer's disease is a common, devastating dementia, which means loss of intellectual function. There are about 25 million people who have Alzheimer's worldwide. There are a lot of Canadians, and there are going to be a lot more as the population ages. And as I say, it's a devastating disease. It takes people away before they die. Now, there is a pathology, that is a structural abnormality that's associated with it. And I joked, we gave this talk earlier, and I joked that I was going to test the people on this slide later. I'm not really going to, okay? But I'll show you what Alzheimer's is. There's the pathology description for the pathologists in the audience. This is what a normal brain versus an Alzheimer's brain looks like. Don't have to be a pathologist to see the difference. And for those of you who know people who have Alzheimer's, one can appreciate what's happened. Okay, so Alzheimer's disease is devastating. We think there may be a fair number of the cases that are caused by reversible blood vessel abnormalities. So let me put that together. As the years go by, and with some of the cardiovascular risk factors like hypertension, there's stiffening of the aorta, which is the blood vessel that takes blood away from the heart. As that happens, it turns out that the pulsatile energy, the pounding that the heart provides us with as it squeezes out blood, there's increased pulsatile energy delivery to the brain. And that increased, and for those of you who I don't know if we have any engineers in the room, we can talk about impedance matching, but in point of fact, you get more pulsatile energy transmission as the aorta stiffens. It damages the brain, and it looks a lot like the slide I'm going to test you on later. So that's what we think. That's what we think that this may be a significant risk factor for Alzheimer's disease. Now, we were in the process of testing that hypothesis. And why is it important? I mean, it's important because if we're right, then it's a potentially reversible risk factor for Alzheimer's, and that's a big deal. If we could reduce the incidence of Alzheimer's, that would that'd be a major advance for us. And indeed, just to let you know, we're using a piece of equipment which combines positron emission tomography and magnetic resonance imaging in one machine with non-invasive pressure determinations. And that PET-MR scanner, which is a very nice tool for research and, for that matter, for clinical work, is a product of Philanthropy, of people donating it. And it's something that relatively few places have. It's a very unusual machine. And it's going to let us do a lot of interesting things. So as I said, the implication of this is maybe reversible. There are certain drugs, for instance, that we use commonly to treat hypertension that actually would increase pulsatile energy delivery to the brain. Okay, and others that also treat hypertension that do just the opposite by reducing aortic stiffness. And so if we're right, then we may find that we should be using some of our effective drugs, but not others. Effective in the sense of treating high blood pressure, but perhaps damaging in terms of producing the pathology that goes with Alzheimer's. So, and the other thing that we want to do is we would like, as part of this center for prevention, to develop a clinic devoted to bringing in patients, both patients who've had problems with blockages in blood vessels and ones who haven't, and try to help them to really apply the most modern, state-of-the-art technology to reduce their risk of having heart attacks and strokes. So this is a clinic that's devoted to it. The clinic also does something else. It gives people access to clinical trials that are ongoing, which generally represent the latest technology. And it's an interesting thing about clinical trials. This is my pitch for participating in clinical trials more generally. People in clinical trials tend in general to get better care than people who aren't in clinical trials. So my pitch for the subject is actually really, it's been demonstrated in various settings. This clinic would be a multi-specialty collaboration of cardiologists, of diabetologists, because diabetes is rampant in the population, and people who do imaging. Okay. Now the second pillar that we talked about in our strategic plan is the whole business of education. One advance in education is the ability to simulate cases, to simulate a variety of things. This is actually a picture of some of them. We can simulate pacer and ICD implantations. We can simulate angioplasty. We can even simulate echoes and certain surgical procedures in the laboratory. And we would like to develop literally the most sophisticated simulation laboratory that we can for training purposes. And a lot of this equipment is largely available commercially now. It's a matter of assembling it into a well thought out training program for our trainees, and for that matter, for our other physicians who want to model a procedure, who want to try something just in the lab before they go live and do it in a patient, maybe even for competency training, although I have some doubts about that. It's safe, it's comprehensive, and as noted, it allows procedure planning and perhaps competency assessment. So this is a part of our educational mission, but we really want to be, we want to do the best job that's possible anywhere for our trainees, as they train to go out and practice medicine and also do research. Okay. And the final one that I want to share with you is, there have been tremendous advances in treating valvular heart disease. It was a remarkable thing that we could put in artificial valves, that we could do operations that fixed valvular heart disease. Monstrous advance. Now, the next steps being taken for increasingly, we're able to put valves into patients just using a catheter. That's a big deal because that way you don't have your chest opened, to do it. The recovery time's much faster. There are people who are tenuous, have other problems that make the operations high risk. This reduces that risk dramatically, that you don't have to do a major operation on them. So we're very interested in putting together expertise. And we have a lot of clinical expertise in our system now for doing valvular disease. We have surgeons who are world recognized figures. We have Eric Horlick and others who are doing really absolutely top-notch clinical work in this area. So we have the substrate, and it's a matter of pulling it together into a center engaged in research, patient care, and teaching that's devoted to valvular heart disease. Certainly would be a multi-center group of cardiologists, surgeons, and imagers. And we think we're excited about that because, again, it affects each of the pillars, or at least it supports each of the pillars of our effort. Okay. All right. So what I'd like to do now is I'd like to introduce Eric Horlick. Eric is a really wonderful proceduralist. He really is. He really is a very talented individual, a guy I have a lot of respect for, and he's going to tell you a little bit about structural heart disease and transcatheter interventions.
Okay, so first of all, I just wanted to thank all of you for taking time out of your lives to come and just see what's going on here. And I just wanted to thank you very much for being donors to the hospital and to Peter Munk Cardiac Centre. And I think really one of the main points I'm going to make during my presentation is that in order for us to innovate and to achieve, you are really very central to what we do. And if we don't say thank you to you at least 3,000 times for every dollar you give, then we're really not doing our job, because we are extremely appreciative. So the question is, what makes you feel alive? So for some people, it's beautiful travel and scenery and mountains and stuff like that. And for other people, it's the arts, it's beautiful music or theater or cinema. For other people, it is just putting the top down and stepping on the gas, and whether that's your car or not. And for other people, it's things like athletics or things like that people love, sports and things like that. And I have to tell you that what makes me very happy, and then what really, thank God they won. They're still playing, otherwise I need a new slide. I got to get Donaldson up there. What really kind of stokes the fire is really innovation. And I love taking care of patients, and I love being on the cutting edge of new therapies and new things to offer to people who have troubles. It is absolutely no coincidence, and it's not just good fortune, that there's a huge culture of innovation at UHN. And that is 100% related to philanthropy and people like you. People who take an interest, people who give of their time and of their resources to help us. Because really anything we do, philanthropy is really very central to getting new projects and new therapies off the ground. If you go to the Ministry of Health of Ontario and you tell them, look, there is a phenomenal new therapy that's going to change the face of the way we practice medicine, you're going to get one of these. We're trying to keep the lights on. Do you know what I mean? Like we don't have any money for that, like at all. $0. Not a little bit, zero. And it's really through philanthropy that you extend a hand to another human being, and that you plant seeds that grow into monstrous trees. Big trees. Very big. I was born in Montreal and did a bunch of training in Montreal, but I am so proud when I go around the world and speak and teach other doctors to say that I'm from Toronto. Toronto is not only known for business and for industry and for culture in this country and around the world, but it's also known for medical innovation. And I am extremely proud of Toronto when it comes to those things. And again, that all relates back to you people. So before I continue, I want to say thank you again. Because if I don't say thank you 3,000 times, I haven't said it enough. So I'm going to take you on a little tour of what I do and some of the things that we're able to achieve and we've achieved over the last short period of time. So, when we talk about intervention in cardiology, what classically comes to mind historically is balloons and stents for heart attacks and angina or pain from the heart, coronary artery disease, and things in electrophysiology where we can apply energy to the inside of the heart to burn abnormal tissue that causes rhythm problems. But when you look at the heart, there is so much more substance there, so many other things to address, but we just didn't have the technology to do it. And really what I'm talking about is the muscle and fibrous tissue of the heart itself, and of course the valves of the heart. The valves of the heart. So I'm going to give you a little bit of history right now, okay? Because history is important to understand where we're going. So I can tell you that I see patients from all over the country and other countries, and I can tell you that when I read surgical notes and what's happened to people, like how did they end up with me, I read surgical notes and I say, you know what, like our guys would never do that. And I just want to appreciate the quality of surgery that exists at Peter Munk Cardiac Centre. These are two senior surgeons, Tyrone David and Chris Findell. And I can tell you that if you need surgery and you're going to have a scar on your chest, you are going to have a masterpiece underneath that. That is not just going to be some hack job, and trust me, there's a lot of hack jobs, okay? This is going to be mastery underneath that scar. But the issue is that we are now in a big migratory phase, okay? And we are going in a different direction than surgery. When people first conceived of the aircraft carrier, right? And people said, what we're going to do is we're going to have a big ship in the ocean and we're going to land planes on it and planes are going to take off of it. People said, listen, you guys are nuts, okay? Plane needs to land at an airport. But yet, people made this work, and in fact, this is very central to how modern warfare is conducted now. We are very committed to the idea that not every solution for cardiac therapeutics needs to leave a scar on your chest. Because, scars are not just about this thing that's in the middle. It's also about that loss of control and that fear and the building up to it and the recovery from it. I was asked for a quote by the National Post when people started talking about transcatheter aortic valve therapy in the mainstream. And the quote I gave them was, the era of the big surgeon, big knife, and big operation may be over. And a lot of my surgical colleagues, not super thrilled with that quote. Not super thrilled. But that being said, there's a lot of truth to that. So let me tell you a little bit about structural heart disease. So what is that all about? So structural heart disease involves treating patients who have adult congenital heart disease. So patients either who are born with very serious problems in their heart that had surgeries as children or as babies or as young adults, and now those operations are falling apart and they need repair, or people are born with less complex lesions that become more important as they age. They become clinically apparent as they get older. Then there's acquired structural disease. And what that means is that's heart disease that you develop in the course of your life. And I'll give you some examples of what I mean by when I say that. and percutaneous valve therapy. And what that means is our ability to treat valvular heart disease without a surgical incision. Okay, let's talk about acquired structural disease. Now, if you look at the top panel, it's a man with a very abnormal looking nipple. Would you agree? The reason why that is because somebody stabbed him with a knife in the heart. And we were able to repair that damage with a device with no scar. And if you look at the bottom panel, that is a 3D printed model of a CT scan. And this is a person who had a heart attack that was so severe, you can see there's a hole. This is looking at the septum, or the piece of tissue that lies between the two lower pumping chambers. This heart attack was so severe that, first of all, it left an aneurysm in the heart, which you can see here, this little hollowed out thing, and actually liquefied the muscle and created a communication between the two chambers. And I'm going to tell you something, that is bad news. That has a mortality untreated of 96% at 30 days. This patient also was treated without surgery. What about adult congenital heart disease? This is the basis of some of what we do in adult congenital heart disease. This patient has a hole in the heart. We have devices that are made out of a metal called nitinol. It's a nickel and titanium alloy. It's a memory metal. When it's manufactured a certain way, it retakes that shape. So we can suck that into a tube, pass a tube across a hole, and then push out part of the device, you can see here, pull it back and shove out the other part, and then you have a closed hole. So what about these surgical scars? You know, people are a little nervous about surgery, right? Pain, loss of control, their recovery period, and are they going to have any disability after surgery? And you know what? These are not concoctions. These are what people tell me in my office, okay? And to be very honest, this is kind of how I feel also. And really what people ask and are most concerned about is, how long am I going to be out for? How many weeks? How long until I feel normal? When can I go to Florida in the winter? Am I going to have to miss this winter? Can I go somewhere else? This is a patient who has a surgical mitral valve replacement. Good therapy. Blood goes from the left atrium into the left ventricle through the valve, and the valve prevents blood from going backwards. So here's an acquired structural heart disease problem. Some of the sutures that are used to attach that valve to the heart fail. And what that leads to is a leak around the valve. Now, redo valve surgery for a perivalvular leak carries a 15 to 37% mortality depending on who you read in the literature. That's a pretty big mortality. What happens when you're 25 and you have this problem? Big problem. Structural heart disease involves dealing with the structure of the heart. So we can take a long needle that's about 3 feet long, we can go in through a vein in the leg, poke a hole through the upper two chambers of the heart, steer a wire through that hole, and deliver a device to plug that hole. And we use that guided by three-dimensional echo technology. So this is the view that I see as I'm trying to guide myself through the hole. And this is what it actually looks like on a patient of ours. You can see here that here's the metal valve seen in profile, and here's a device that's in the hole. And this is exactly what the echo looks like. This is a patient with a single device. This is a patient who has two devices in to plug a hole like that. What's exceptionally neat is we have a partnership where we're going to have a worldwide exclusivity on a new technology that allows us to visualize things instead of on a flat screen, but as a three-dimensional hologram. When you think about this, like when I think of hologram, I think of like Star Wars. I think of like R2-D2 projecting Princess Leia, you know what I mean? And this is just going to become part of the art. I mean, we're going to evaluate this, obviously. This is a brand new technology that we're going to happen to have first. But I mean, this is an amazing, conceptually interesting thing to help guide procedures in the heart. We have other technologies for things like heart failure. When people feel short of breath and they have heart failure, it's because their left atrial pressure becomes elevated. That gets transmitted back to the lung, you make lung water, and you become short of breath. So we have a technology with a device that's going to enter into a clinical trial later this year where we can actually make a hole and keep it open between the upper two chambers of the heart to decompress the left atrium. That's neat. Atrial fibrillation. I can tell you that there's probably 15% of this audience who has atrial fibrillation. No show of hands, please. And I can tell you that there's a problem with atrial fibrillation. Atrial fibrillation, you can see, there's a part, this dead end corner in the left atrium called the left atrial appendage. And this is what it normally looks like. And normally it beats with every beat of the heart. But in atrial fibrillation, it doesn't beat. It just stays still. And what happens is you can form clots inside that blind piece there. And then that leads to stroke. And people who have atrial fibrillation have about a 6 to 12% per year rate of stroke. And we treat them with blood thinners. But what happens when you take a blood thinner and you have blood in your stool? You have blood in your urine. You cough up blood. It's a big problem. So what we have is a new technology to actually close off this chamber. So to reduce the risk of stroke in patients who cannot take blood thinning drugs. Let's talk about valves. For the connoisseurs in the audience, this is a Mercedes AMG engine. This is a really good engine. Really good. So in the past, the only thing we had were balloons. So this is an example of blowing up a balloon in a blocked pulmonary valve. And you can see here that there's a waste on the balloon as it goes up right here, and the valve cracks. So for the pulmonary valve, that works well. But for the aortic valve, which is a far more common problem, especially in people as they age, the balloon does not work well. This is a normal valve. The tissues are thin and pliable, and this is a hard, calcified valve that's immobile. This is a painting called The Golden Age. And you know what? When you grow up and you talk to people and whatever else, you figure that if you need surgery for something, you can just have surgery and they'll fix it. You don't love it, but they'll fix it. The problem is about 30% of people who have aortic stenosis are not candidates for open heart surgery, too high risk. And for those people, the dream kind of dies. And you know, when I would see people in 2007, some of these 30% of people who couldn't have surgery, these are people whose lives are shot. These are people who, you know, I sit with a couple in my office and they say, you know, well, he feels terrible. She feels terrible. He's been in the hospital in the emergency room twice in the last 3 weeks. Like, can you do something? And you know, if you really want to know what desperation is, it's when you run out of options. These people have chest pain, they faint, they get shortness of breath, and in people who cannot have surgery, who have severe aortic stenosis, who have symptoms, there's a 50% one-year mortality. That's a big number. In 2007, we were the second hospital in Canada, the first in Toronto, first in Ontario, to start using this technology to replace valves. And this was very crude, and I will tell you that it is the equivalent of a World War II airplane, okay? Do you want to really go into battle in the World War II airplane? Like, you know, sorry, pardon me. Clearly someone knows more about military aircraft than I do. I'm going to set you up with Domanski. He knows a lot about that stuff. And over the last just few years, we've really improved this technology and have slicked it down. So now it's really the equivalent of a stealth fighter. These things are amazing at this point. I want to show you this study. I'm showing one study in this whole presentation. Normally when I speak to audiences of doctors, I speak about only literature. This is a study, the most recent study using a prosthesis called CoreValve. It's a new way to replace the aortic valve. If you look at these two curves, this is 12 months out of surgery. This is transcatheter valve. This is conventional surgery. We've gotten to the point that there's an absolute 5% reduction in mortality at 12 months using TAVI, or minimally invasive aortic valve replacement, versus conventional surgery. That's incredible. Surgery is the gold standard, and we beat the gold standard. There's also less stroke in these patients as well, which is another key indicator of success. How does this look like? Well, we cross over your valve using this valve stent. We pace the heart very rapidly, about 200 beats per minute, so nothing moves. And then we just blow up a balloon and deploy the valve. There's no leaking, it works immediately. So what does a TAVI feel like? Well, don't blink because you may miss it. It only takes 25 minutes. So you will be comfortably sedated. You will be breathing on your own, no general anesthesia. Your heart will be beating normally. You're not going to have even a urinary catheter. And guess what? The vast majority of the time, you're going to be home tomorrow. It's not only about doing procedures, it's about helping to build the information base to allow us to say that this is going to be better for you. And Peter Munk Cardiac Centre is all about building the data, doing the research, doing the heavy lifting to establish therapies as being important or unimportant, things we should discard, okay? And we had a leadership position in these two major papers published in the Journal of the American College of Cardiology, which is a very high-end cardiology journal. 22 other publications came out of this program. In fact, the success of this program has really led to percutaneous valve therapy being an essential part of the brand. Just like the iPod is a very strong part of Apple's brand or the iPhone, percutaneous valve therapy is a very strong part of UHN's brand. What about pulmonary valve replacement? A less common procedure, more in congenital heart disease, but I can tell you that we performed the first one of these in North America in 2006, and I can also tell you that on a planetary scale, nothing happens in development, education, or otherwise in this area without the inclusion of Toronto General Hospital and the Hospital for Sick Children, who are our partners in this program. We're involved in device development, teaching physicians how to do it, and trying to figure out new ways to extend the technologies. This is just an example of something we've recently done. We've recently completed a 3-center early feasibility study for a brand new therapy for the pulmonary valve. And something like this, if not this exact thing, is going to eliminate surgery for this valvular heart disease. And we'll see more of that coming very shortly. So what's in the future? I just have 3 more slides. What's in the future for what we're doing? Well, I think one of the most exciting things that's come along in the last 5 years is the ability to replace the mitral valve with a new technology. Whereas the aortic valve is in a tube, and it's very easy to stent tubes, the mitral valve beats and opens and closes as the heart shortens as it contracts and twists as it contracts. It's a far more difficult space to be in. We're part of an early 20-center feasibility study for this brand new technology that very few people are going to get access to. And again, this is one of those things where the people of Toronto, Canada's really premier city, need to have access to technology like this when they're in trouble. And that's why we go out and leverage our relationships to make sure that we have these therapies to offer. Second is another therapy for the tricuspid valve, which is a valve that's often not treated surgically because the risk of surgery is very high. These people have swollen feet, they have swollen livers, they lose their appetites, and really contribute to quite a miserable quality of life. We have a new device to repair the tricuspid valve called the Forma device. This also will be entering trials. We're just finishing our ethics application now. So I'm going to stop here because there's a lot of stuff. Sorry. And I'm just going to summarize my comments and just say, first of all, thank you, thank you, thank you. If I don't say thank you enough, I'm sorry. Really, thank you. I'm going to tell you that every one of these technologies that I've showed you we get our start with Philanthropy. We can get some cases done, we get some procedures done, we sort it out, and we go to the ministry and say, hey, in Ontario, this works amazing. It needs to get out to the rest of the province. You need to fund it. The experimental therapies of today are going to save thousands of lives in the future, and really Philanthropy allows you to really have a part of that. And that is really a way to feel good about money that you spend, especially money you spend in charities. And I think your generosity really allows PMCC to be at the heart of innovation, evaluation, and application of early stage therapies. I'm going to stop there. Thank you very much.
Thank you, Dr. Domanski and Dr. Horlick. That was absolutely fantastic, and I hope you all learned a lot.